Shock. Shock is defined as inadequate oxygen and arterial blood flow to the tissues and cells. This is a life-threatening condition. It can be caused by a decreased blood volume, the heart failing as an effective pump, and peripheral blood vessels that massively dilate. If untreated, organ damage or death will occur. We talk about four categories of shock. We have hypovolemic, distributive, obstructive, and cardiogenic. Hypovolemic shock is the most common type. We have a significantly diminished amount of extracellular fluid. It can be caused by blood or plasma loss from surgery or trauma or birth, etc. It can also be caused by fluid loss from burns, large draining wounds, or suctioning. Symptoms are going to begin to be evident when we have a fluid loss of 750 to 1500 mLs. It can be life-threatening when we reach a level of 2000 mLs lost. Distributive shock is also known as normovolemic shock. It's caused by the amount of the fluid in the circulatory system not being reduced, but at the same time, we have ineffective tissue perfusion. Vasodilation is present, but we have a reduced central blood flow. So basically, what's happening is we have our normal amount of blood in the blood vessels, but due to circumstances, we have massive vasodilation. So those blood vessels are getting larger, they're dilating. And because of that, that normal volume of blood is no longer enough to fill those expanded blood vessels. So we can develop what we call distributive shock. We have three different types of distributive shock: neurogenic, septic, and anaphylactic. Neurogenic shock is the rarest type. It can be caused by spinal cord injury, opioid overdose, tranquilizers, or general anesthetic. It can also be caused by decreased arterial vascular resistance, vasodilation. We're going to start seeing hypotension and reduced cardiac output, and metabolic acidosis is present. With septic shock or toxic shock, this type of shock has the highest mortality rate. Causes of septic shock are bacterial infections, maybe from Escherichia coli, Pseudomonas, or Staphylococcus aureus. These endotoxins produce harmful chemicals. We are going to see an elevated white blood cell count. The client will have a fever. They'll be warm and have flushed skin initially. They're going to have a rapid bounding pulse that progresses to cold, pale skin, and they become hypotensive. This is the only shock where the skin is going to be flushed and warm, even though it's only for a brief or a portion of the time. As septic shock progresses, we begin to see systemic inflammatory response syndrome, or SIRS, and multiple organ dysfunction syndrome. And anaphylactic shock. This is caused by a severe allergic reaction, a lot of times from bee venom, latex, fish, nuts, or penicillin. Again, we have massive vasodilation with increased capillary permeability. The tissue in the airway begin to swell, and it can actually close off the airway due to the swelling. We see hypotension, hives, and an itchy rash. With obstructive shock, we see an interference of circulation of the blood in or out of the heart. And we also have a compromised blood flow to the lungs and the tissues. This can be caused by cardiac tamponade, the tension pneumothorax, ascites, or an enlarged liver. Cardiogenic shock, we have an ineffective heart contraction. So this causes a reduction in cardiac output. It can be caused by myocardial infarction or heart failure. And with the older adults, we need to consider that they can be at a higher risk with a history of cardiac disease. They also have a decreased percentage of body water and a decreased immune response. Questions. The client has an elevated leukocyte count and initially manifests a fever accompanied by warm, flushed skin and a rapid bounding pulse. What type of shock is this client most likely experiencing? The client is experiencing septic shock. So let's talk about what happens when a client is in shock. We go through three stages: compensation, decompensation, and irreversible. In the irreversible stage, we see multi-system failure of the kidneys, the heart, the lungs, the liver, and the brain. In the compensation stage, so the very first stage, physiologic mechanisms for homeostatic stability are going to be activated. In other words, the body's going to try and correct what's going on. Catecholamines are released, and these stimulate the sympathetic nervous system. So we see an increased heart rate. We see increased myocardial contractility, an increased venous return, and bronchial dilation. We also see the renin, angiotensin, aldosterone system being activated, and this is going to help restore the blood pressure and increase the blood volume. And we also see the release of the antidiuretic and corticosteroid hormones, the ADH and the ACTH. They're going to be secreted, and when they're secreted, this helps control sodium and water balance. So basically, our body's going to work to compensate the deficits it's beginning to feel. We're going to start holding on to water. We're going to start having a faster heartbeat to get the blood to the tissues. We'll start breathing faster, so we're taking in more oxygen for that blood to carry to the tissues. So holding on to water, breathing faster, and the heart is beating faster. With the decompensation stage, this is where the compensatory mechanisms begin to fail. We're going to start seeing cellular hypoxia, which is decreased oxygen in the cells, and this can result in cellular damage and destruction. We're going to start seeing coagulation defects. This will be an inflammatory response to cell damage that leads to the formation of microemboli. So in other words, we start forming little tiny clots. And we're going to start seeing cardiovascular changes. We have impaired myocardial cells that cannot maintain a sufficient heart rate, and the force of contraction. So now the blood pressure is really starting to fall. The irreversible stage is where we see significant cells and organ damage. There's no response to the medical interventions that we're doing, and the client is now going to reach a point of no return. So it doesn't matter what we do, we're not going to be able to save them. We see that multiple system failure of the kidneys, the lungs, the liver, and the brain, and death will be imminent. A client is somewhat disoriented with blood pressure lower than the earlier assessment and pale skin. Which stage of shock is characterized by these physiologic changes? This is the decompensation stage. As we're assessing a client for shock, with our primary assessment, we're seeing the effects of compromised blood volume or circulation. And we can see that in the vital signs. Again, an elevated heart rate, an elevated respiratory rate, but a lower blood pressure. We're going to have weaker peripheral pulses. Pulses are often weak and what we call thready. We're going to have changes in the level of consciousness, so the client may no longer be cognitive. We're also going to see pale skin because we're shunting the blood to the vital organs, which are the heart, the lungs, and the kidneys. We don't need it in the skin, not the kidneys, the brain. We don't need it in the skin, so all the blood from the periphery is now going to be shunted to those vital organs. So once again, the heart, the lungs, and the brain. And we're also going to see decreased urine output. The body is trying to survive. It's trying to elevate that blood pressure by keeping an elevated fluid volume. And it does that through that renin, aldosterone, angiotensin component, the ACTH and the ADH release also. We do have the Apache scoring system that we can provide some measurable issues for our shock status, and that would be, again, the Apache scoring system. The higher the score, the higher the risk for the client's death. It stands for acute physiology, age, and chronic health evaluation. With the arterial blood pressure, the systolic and diastolic pressures are going to begin to decrease. The client is going to be hypotensive because of decreased cardiac output. Again, we don't have the volume sufficient to perfuse to the body, or the pump is not functioning appropriately, or we have too large a space to fill with the available blood. So now the amount of blood that we're able to pump out of the heart is decreasing. We should be doing direct blood pressure monitoring. We can also do intra-arterial and oscillatory methods are going to be preferred. The pulse pressure, which is the difference between the systolic and diastolic pressures, are going to start narrowing. In other words, they're going to get closer and closer together. The pulse is going to help determine the severity of the shock. The rate initially is going to be tachycardic, but once it starts going bradycardic, that's when the client is really in trouble. Again, the volume, it's going to be weak and thready. And the rhythm is going to start becoming irregular. Respirations are going to be shallow, grunting. The client may demonstrate air hunger, and the respiratory rate will start to decrease. Again, this is when the client is getting into some severe trouble. The temperature, we have an increased heat loss, except with the septic shock. So the clients are usually cold, which means we need to keep them warm. And it's often going to be subnormal. We have an altered cerebral function, so we have a change in mentation. We have a change in the level of consciousness. The client may start off as being anxious or restless. They become agitated, confused, and they can progress to loss of consciousness. Again, with the skin, it's usually cold and clammy, pale. It may be mottled, where we have the splotches. We have an increased capillary refill time, so it's slowed down, and we may see cyanosis. And once again, urine output is going to decrease, so we start seeing oliguria. And as the kidneys are not one of the vital organs, we could potentially see renal damage. How do we diagnose shock? Well, we need to look at our ABG measurements, our arterial blood gases. We're looking at the PaO2, the CO2, and the SaO2. We're going to maybe do some central venous pressures, where we're basically determining the pressure on the right atrium. If the client is hypovolemic, that CVP, or central venous pressure, is going to be lower than normal. If this is cardiogenic shock, it may be above normal. We can also do pulmonary artery pressures, where we're checking the pressures on the left side of the heart. The pulmonary artery pressure, or PAP, pulmonary capillary wedge pressure, PCWP, they're going to be lower than normal. Which of the types of shock is caused by severe allergic reaction or spinal cord injuries? Our distributive shock. So how do we treat shock? Management requires aggressive treatment. We're going to administer IV fluids, the crystalloid solutions, maybe the colloid solutions, including albumin, and packed red blood cells. We're going to give drug therapy, such as vasopressors. Vasopressors are going to increase the blood pressure. These medications may include dopamine, norepinephrine, or vasopressin. We may also give some inotropic agents to help improve the contractility of the heart, and this can include digoxin, dobutamine, or miloronin. Mechanically, we may insert an intra-aortic balloon pump, or use a ventricular assist device, or even the masked trousers. So let me explain masked trousers real quickly. These are basically trousers that are put on. They are kind of the Velcro opening, and then we close the Velcro over each leg. There's two parts to close on each leg, and then there is the abdominal portion that can be closed. There's a pump that attaches to these masked trousers. These are called military anti-shock trousers. That's what MAST stands for. Once these are in place, then we begin pumping up the pressure inside those trousers. So basically what's happening is as we pump up the pressure, it's going to start pushing the blood out of the legs towards the vital organs, the heart, the lungs, and the brain. And we're checking the client's blood pressure to determine if we're reaching acceptable levels. If the lower portion of the legs is not sufficient, we can pump up the next portion of the legs. If that's not sufficient, then we pump up the abdominal area. Now, the big thing when we remove masked trousers that we need to be aware of is if we just take them off, we're going to cause that client's blood pressure to drop drastically and potentially kill the client because of the sudden severe hypotension. So we have to do it very slowly, and we have to monitor the client's blood pressure as we release the air. Client recovery is going to be dependent on the adequate and prompt treatment, but complications can affect the recovery. Life-threatening complications would include kidney failure, neurologic deficits, and bleeding disorders. Acute respiratory distress syndrome, or ARDS, stress ulcers, sepsis, and multiple organ dysfunction. And your post-test.